Okay. Can you all see my slides? No, because I haven't
Not
shared
yet.
yet. That's why.
No.
How about now?
Yes.
There you go.
There we go. All right, so some of you have seen me give my song and dance on FRQ before, but it's been a few years. Do we have any FRQ super users in the audience tonight? Maybe a couple?
I'm here.
All right, perfect. So some of this will be a refresher for you. And for the rest of you, FRQ is Functional Recovery Questionnaire. That's what we're talking about today. And I think the reason that the FRQ started, gosh, it was probably in 2010, 2008, 2010 is when the big effort started to go forward with this, is that there's this disability conundrum that, about 5% of work injuries end up unfavorably, where they're permanently disabled, they lose their career, their benefits, all this stuff happens to their families and lives. And the biggest tragedy is that in the first, few months, they look exactly the same as everybody else. Low back pain is one of the most common reasons for that. And yet, weeks 2 through 6 or so, they look the same as everyone else. So how do we identify who those people are and help them before it's too late? And too late looks like it's probably around 3 months is where it starts becoming too late. So this blue line is the actual numbers from disability, where we look at percentage of cases that are on time loss at this after these first few weeks. So by month one, half, 55% of people have gone off of time loss and gone back to work. By month 2, we're slowing down a little bit and it's only around 45%. And then by month 3, the curve is really flattened out and we're, just a little less than 40%. So we're not seeing much of a drop by that point. And so the thinking was, how do we identify people and then do something about that early on? Because by the time you get out to 3 to 4 months, it becomes harder and harder to resolve whatever issues they have and put them back to work. And so if we can drop that even a few percentage points up here early, then that'll greatly affect the curve as we go forward, right? And people that would never otherwise have gone back will already be back. So that's the goal here, is that we're reducing that disability and we're doing disability prevention in the first 3 months, where we can really do something about it much more easily than turning a claim around that's 4, 5, 6, 9 months old becomes much more difficult. So why do we use the Functional Recovery Questionnaire? Well, the average worker has about a 2% risk of remaining disabled 1 year in the future. So if you took all claims on, day one, only about 2% of them make it out to a year where they're disabled and ongoing. Whereas in Functional Recovery Questionnaire positive workers, it's about 40% of them. So that's a huge increase. We're talking, right, 20 times more likely to be disabled. And so if we're going to expend effort, right, it should be on these people because they have 20 times more risk of that problem. Now, the savvy people here will say, well, wait a minute, only 40% of those FRQ positive workers are going to be disabled anyway. That's not that good. You're right, but it's a lot better than 2%, which is kind of what we're shooting at right now. So if you just take a random claim that you're working on in the first couple of weeks, it's only got about a 2% risk. If you take an FRQ positive, it's got about a 40% risk. So that's why you'll see lots of them that recover just fine. We expect that to happen. You'll think, well, I don't think this is a big deal. It might not be, but it's about that expenditure of effort at the highest risk person. And, ideally, you'll see every FRQ positive be fine, because that means you've done something and you've changed it. And I think that's one of the big shifts too, is to think about, FRQ positive just means they have risk. It doesn't mean they're already, a problem or that they're disabled. It's that we need to do something to help them. And if you do your job and the AP does their job at addressing these issues, then none of your FRQ positive workers should be disabled later. That means we saved them. And I would be extremely happy if none of our FRQ positive workers ever became disabled, 1 year into the future. Wendy's working right now on looking at data so that we can see, how many FRQ positive workers are there and what happens to them, and have we intervened appropriately, and what kind of things are going on. And maybe someday in the future, we'll be able to report that data back out to you, but we're still working on the technical aspects of it at the moment. But that's kind of how we'd measure success, is that someone who's highly at risk doesn't end up having a problem. And I think about these questions, question one about are you on time loss? Question two, how much does that affect you, right? You're on the scale of pain interference. Is it more than a 5? And are you having multi-region pain? Those are the first 3 questions. That really kind of addresses where providers are at, thinking about focusing on their increased activity, their functional progress improvement goals. If they're saying, yeah, I have problems with all of that, then we can consider different kinds of referrals to that. Questions 4, 5, 6 are more of the trying to understand why they're having those barriers. So question 4 is around their connection to VOC. So maybe that triggers a vocational recovery referral. And that can happen on the claim side of things. If you guys make a FRQ note, that will trigger something in our system for the claim manager to look at it. And probably their reaction is going to be to look at question 4 and say, maybe they need VOC. The downside of relying on the claim manager to figure something out is that they don't know the worker like you may have, right? And certainly not like the attending provider does. So for all of these, I think it's really imperative that the attending provider is thinking about what these solutions are, because they probably had the most conversations with the worker about what these issues are. Or you may have discovered things in your FRQ questionnaire delivery that you can say, okay, here are the key pieces or the good referrals that would be helpful, and make that suggestion to the attending provider. The claim manager doesn't have any insights into that most of the time. And then the last 2 questions, 5 and 6, are more about their expectations, right? Their recovery expectations and their fear avoidant behaviors. And so those are things where, we might consider behavioral health or PGAP to try to intervene with those, or just having the attending provider looking at those pieces and addressing some of those psychosocial barriers with interventions that either they're able to do or that they can refer out for somebody to do. We pulled this flow chart from the psychosocial determinants influencing recovery document, which hopefully, you've got it right there with your FRQ, because I think it's a great resource to understand then what do we do about this. So if you've asked that standard workup, and we're really thinking about this in your head of, is everything okay with this person? If yeah, they're fine, then, checking in a week or 2. This is the guidance that we give to providers. If they're back to work, great, then, we can keep going. But if they do have some of these factors, then you think about, is everything going to be okay in 6 months? And do they have a positive FRQ in the file? Then that now is when we're thinking about other kinds of disability impact scales, or more focused, like stress or anxiety kinds of scales, working that up and figuring out what would be the right implementation of referrals, therapies, coordinated care, or whatever to address those issues. And this is the FRI. So by the time you've done an FRQ and you're having a conversation with that attending provider, this is kind of where you're at. You say, hey, provider, this is a positive FRQ. What are we going to do about this? Here is a flow chart that looks at some of the potential interventions for that. Questions 1 and 3 establish that it's positive, and then 4, 5, 6 really guide the next steps. So things like, how do you coordinate return to work and VOC? Are there activity coachings or behavioral health referrals? Things the provider can do, like a fear avoidance belief questionnaire, to kind of get at what's going on, if they're already in physical therapy, and we just need to assess that. And then have the therapist think about, how do we work with somebody who has these fear avoidant behaviors? Or for the AP team to consider other things like activity diaries, coaching, whatever it is that provider can do. And it may just be that they need to have more visits with them, or need more, high touch. They need a call once in a while to check on or reassure them of how things are going. And there are lots of resources in the PDIR for attending providers. We've got messages about key recovery, so kinds of the things that you should be saying to this person to reassure them and move them forward. And also guidance on if you see certain attitudes and behaviors and beliefs, how to address those. So assessment of barriers to recovery. You're going to conduct a functional recovery questionnaire and then reporting that positive FRQ to attending providers. Now, this is really the big step that started in, I think it was about 2020 when we moved from, okay, yes, the FRQ looks like it's going to work and we figured out how to administer it, to now we need to do something about it. We actually have to reach back out to attendings and say, hey, there's a problem here. How are we going to address this? And I know many of you get yeah, I already know it's a problem. There's some providers that have been doing this for a long time that are good at spotting this stuff, or already have a plan for them. That's great. But I think the main catch here is that not everybody does. And that's how workers fall through the cracks. And we're trying to avoid that from happening, because not every provider is going to notice those things. You yourself may not notice some of those people that, in the first 2 to 6 weeks may have the inklings of problems, but it hasn't manifested yet. Maybe they still have a good attitude about it, but the train's coming down the tracks. So helping to start that conversation with the provider who may or may not know all the options available in the L&I system. If they're an OCMED provider in an OCMED clinic doing this all day long, they probably already know. If this is, they only get 3 or 4 cases a year, they may not know any of these resources. So making sure that they know what's available, what their plan is, and including that in your coordination plan. That way the CM knows, they can look at your note and say, okay, the provider's actually doing something about this, or we've referred to VOC, and can communicate with them and make sure everybody understands that this is a problem. We're also training VOC providers to look a little bit more for FRQ notes and positive FRQs and what to do about those and how to intervene. So this is a team effort from CMs, HSCs, APs, BRCs. We're all looking at the same thing. You also see barriers to recovery showing up in the PMPR form, which is the physical medicine progress report form that PTs and OTs do about once a month. The backside of that is section 4 barriers, and it's got some of the same language. Again, trying to alert the attending provider or the VOC person, anyone looking at the claim, that here are some things that we're seeing in therapy. And then documenting pain and function scales. So making sure that there's progress, particularly in someone we know that's at risk, having that attending provider, if they haven't already used an outcome measure, making sure that they do that so we can track how things are going and show that there isn't progress and we can intervene, or that there is progress and they're doing okay. That way we can see what's happening. All right, so here's kind of the overview. Workers' compensation perspective of injury is like, you have this injury, right? There's the accepted condition. That's who this person is. Now, of course, that's not the case though, right? There's a full picture around this person, that they have tons of other things in their life that are going on. And this injury only makes all that other stuff more difficult. And all that other stuff gets in the way of them recovering sometimes too. So understanding all these different pressures and kind of thinking about those, and coming up with strategies of how to work through that. Stress is a normal part of life, and we all develop coping strategies for it. Some coping strategies are better or work better than others. Some are a little dysfunctional, and depending on how that worker has created coping strategies, they may be fine or not. So it kind of all boils down to this basic question of, can you handle everything that's going on? And some people can, and some people can't. I always tell the story about my wife who does pediatrics. So she's a chiropractor as well and does infant breastfeeding, perinatal stuff. And she would go through a box of tissues every few days in her clinic. And I worked on site in a corporate practice where everybody was at work. We never went through a box of tissues. We'd have to like wipe the dust off of it when someone needed one, because it's just such a different setting and the people are having different experiences there. And so those circumstances and the implications they have and the stress that's placed on them while they're undergoing these make a huge difference, even if it's the same injury, right? They can both have low back pain and have very different experiences. I think we need to, consider screening to assess underlying factors. or reasons that there's a less than expected improvement, looking at all these PDIR factors, which the 6 top ones are their recovery expectations. A lot of this is attitude, their fear of activity, whether that's return to work activity or whether that is the rehab activity that they're going to do. If they're not engaging in their rehab, they're not going to make progress. And even if they did and they're functionally fine, but they're worried about how they go back to work, right? Those could be barriers as well. Loss of that vocational connection, just knowing that your employer, is waiting for you to come back and excited to have you there, and your coworkers are, encouraging you to, makes a big difference on people's improvements. So creating that vocational connection, getting them talking to the employer, finding accommodations, really important. Deactivation, this gets worse the longer they're off work, particularly if they have a demanding job. If it's been 6 weeks, and they haven't done it, they're going to be a little bit rusty. I think we all experienced what deactivation means during COVID. We're locked down, nobody can leave, you can't do anything, it disrupts your routines, and it can be very disruptive to your life. And in fact, we've seen a lot of mental health, substance abuse issues coming out of the COVID years. Catastrophic thinking is another one where this could be, they view that their employer put them into this job or had them do this task because they hate them and they're just trying to get rid of them, and that's why they got injured. So there could be a lot of catastrophic thinking around that, or it could be, I'm never going back to work again. This is a complete disaster. What am I going to do? This stuff always happens to me. Can be very destructive thoughts, and depending on the level of severity, they may need counseling, or just support from the attending provider. And then perceived injustice is the last one. I think this is pretty common in the work comp system, that they feel, the claim manager is ignoring them on purpose, or that, we're denying their benefits or whatever it is, that those miscommunications, the delays, all that can create that sense of injustice for them. And then I think it's important for the AP to know limitations and specialties. So providers really need to know, where they can turn to for different referral options, and what they have in their community might be different depending on your institution, your locality, whether you're rural, who else is in the area. Who do you go to when somebody needs active rehab, PT, OT, chiro, activity coaching, where are those located in your community, if there are any. Psychosocial care, we have both the psychologists and the master's level therapists. So behavioral health interventions are really important. This is not the same thing as mental health interventions, right? Behavioral health interventions apply to the accepted condition. They're able to treat them without going through, a lot of authorization. They just need a written referral. And the master's level therapist pilot has been a big success. We have about 100 providers that have come on with that. It's going to become permanent in January 2024. So we'll kind of streamline the behavioral health delivery and hopefully open that up, and more people will join when it's a permanent program. And then thinking about employer engagement. Usually that's the role of the VRC, but there could be other people that are engaged with that employer too. So functional recovery interventions options by specific risk factors. If they have activity avoidance and unreasonable fear of worsening, how are we going to intervene with that? Usually that's, probably activity coaching is kind of the where most people get that from. Page 13 and 14 of the PDIR has a table essentially, and it goes through each of these things, right? If you're seeing family support system issues, here are the kinds of resources that can help with that. Counseling, they can bring their family in. And so I've linked it there, lni.wa.gov/psychosocial. And it's a 2-page table. It looks a little bit like this. We have an example here of that activity avoidance and unreasonable fear of worsening, right? If you see these kinds of behaviors or symptoms, then here's what an attending provider can do. Some actions they can do, and then some additional support resources that are out there, things to try. And we have that for each of those 6 different typical barriers to recovery. and several different options for each one. So hopefully, in that grid, an attending provider can find something that's useful for them. And I really encourage you to, send this out to providers who just don't know what to do or don't know what the options are. I think this could be a really useful resource for them. They don't have to read the whole PDIR. They can just look at these 2 pages and get a lot out of it, out of very practical sense of what to do. Already talked about behavioral health interventions a little bit. Really, they just need that AP referral. You can find them on Find a Doc. So they're listed under specialty providers, and then it's behavioral health, and it'll have all the different master's level therapists in there. And they get up to 16 visits for the life of the claim right now. We're looking at whether that limit will change or not when we do our new payment policies for January 2024. And they can do telehealth or in-person visits or some audio only as well, whatever they can get access to. And these are the things like, pain behaviors, their beliefs about recovery, the coping strategies and attitudes they have, all those pieces that are probably just, part of the mix of who they are and part of their recovery or lack of recovery are things that can be addressed. If you get injured and aren't working, you're going to have concerns, right? It'd be normal for you to have that. And so all the stuff that a behavioral health intervention addresses are the normal pieces of recovery. The limitations they have of why they're not getting any better. So prevention strategies really boil down to this. We got to identify who's at risk, right, from everybody who's contacting the worker and be alert to that, and then have some effective interventions to address their individual risk factors. People often ask Elle and I to figure out what that intervention is supposed to be, and I tell them, I don't know, right? We can't know. We don't interact with the worker at that kind of level. So we really do rely on the HSCs, VRCs to make APs to make those kinds of determinations. And then we have to intervene while it's still a modifiable risk, right? We want to intervene as early as possible, somewhere around, month 2 or 3 at least, but some people might need that a little earlier. And then give them better empowerment and coping skills for the worker so they can move through those issues, work past those barriers, and then better coordination of system variables. And that's where you and your ability to, grease the skids and get communication happening between the AP, the worker, the VRC, the claim manager, the PT, all the people that need to know these pieces of information. You're kind of making sure that that shuttles around and that everyone understands those. Okay. Any questions? Let me look at my chats and slideshows. Let's take a pause and see. Any questions about FRQ and psychosocial determinants so far?
What was the URL for the, this is Patty Frazier with Cokie in Spokane. What was the URL for the, for that PDIR?
For the PDIR, it's lni.wa.gov/psychosocial.
Psychosocial.
I told my marketing people, I don't know how many people are going to be able to spell psychosocial correctly. I struggle with it, but if you can spell psychosocial, that's it. And you can also navigate it to it from where we have all our guidelines and resources for attending providers. It's in there too.
Morgan, can you share the research data on development of the FRQ?
Yeah, so that came from the de-risk study. I don't remember what that acronym stands for off the top of my head, but that was in 2008. And they took about 2,000 people with low back pain and gave them pretty extensive surveys and questionnaires in that first 2 to 4 weeks after their injury, and then waited a year and looked back and followed up with all those workers to see what happened to them. And then they took the people that had become disabled and looked at those risk factors of, what did they have that the people who were fine didn't have? And they tried to correlate all those pieces out. And that's how they came up with those 6 factors that are in the Functional Recovery Questionnaire. And then the 3 that were the most important were the ones that time loss, pain interference, and multi-region pain. That's what kind of predicted that they would be the most on time loss. And then the other 3 were like the secondary factors.
I guess I was looking more for for the document to share with a provider who's asking about how this FRQ was normed and how many participants this was based upon. I think I remember seeing that information,
Yeah.
but I was wondering if you could pass that out or share that.
Yeah. I will send that to Wendy. I've got a PDF of it and she can send it out to the group. Does that work?
Sounds
Yeah,
great.
that should, as long as I can print it and share it.
Yeah. Yep. It's a PDF. But yeah, it's 2,000 people with low back pain. That's 2,000 workers with low back pain. That's the gist of
And
it.
they were administered the FRQ?
No, they were administered a whole bunch of questions, and these were the factors that predicted disability.
But was the FRQ tested and normed?
So they did that in like 2010, where the Cohees, saw how practical it was to give it out. And that's where we did all those learning and development on, what would be practical and feasible, whether providers would do it. And we found that it wasn't practical for them because it was so rarely head positive. I'm not exactly sure what else you're asking for.
Okay, I was thinking there was data actually on who this was normed on and that the FRQ was actually tested itself, the FRQ document and research was done on that. Sorry.
Yeah, no, it's just done on, these are the risk factors that predicted disability. And so that's what became the questionnaire. Yeah, because it's
Okay,
not identifying like a condition in them or anything. It's really just seeing if they have those same risk factors. And that's why it is only a screening tool, right? It doesn't say that they have something or not. It says they're at a higher risk than other people. And therefore we need to do something about that, right? And intervene with them. And that's where that AP interaction and your interaction with the worker really is what makes it effective, is figuring out that something has to be done. And I know that some of you figure that out before you do the FRQ on some people, and others of you have commented, hey, this one caught one that I didn't think would be a problem. So it's not a perfect solution for that. It's just a tool that tries to standardize the identification of those workers. Particularly, I think, useful for people that haven't been doing this for very long, or busy practices, to ensure that they catch those people and not let them slip through.
got it. Thank you.
I think often we've done so much work on this and talked about it so much, people want the FRQ to be more than what it is, that it really is just a screening tool for risk factors and a prompt to, hey, help this person out. This is a flag. Okay. We've got a few scenarios here, and I think this will kind of underscore what we were just talking about too, is that people asked about, what if the employer doesn't offer light duty and the worker's not working? Should we still do an FRQ? What if the claim's undetermined, or they already have a VOC assigned? Or maybe the claim manager or the HSC asked them a couple of these questions already during their first call, or what the claim managers refer to as mapping conversations. Or if the provider does an assessment of barriers to return to work, should we still do FRQ? And my answer is yes, because VOC isn't always the solution to an FRQ problem. Sometimes there are other solutions. So just saying, well, they have VOC, they don't need FRQ, that's not the full picture. And the assessment of barriers, again, when does that happen in the claim? Is the provider consistent with doing that stuff? All these pieces are that FRQ is a standardized, reliable, triggered thing that always is going to happen for these certain criteria. And so it's beneficial to do that so that we get that baseline data and make sure that nobody falls through because that provider was out that week, and so they didn't get an assessment of barriers, right? Claim undetermined, again, if there's a bunch of issues and barriers with that, it'd be nice to know those things, even if the claim's undetermined. So that's why I am pushing this to say you should still do it and should still have that be a triggering factor It's important in our system on how the claim manager looks at it. We're doing more things that are based off of FRQ positive and intervening on those things. So I think it's an important data point for us to have too, to flag that. Reporting. Wendy, do you have an update on reporting that we can share without?
So I don't have a specific update at this time. We are still working on the reporting components of this. And hopefully once we have them, they will be able to come out in both the COHE level reporting and the provider level reporting.
Right. Oh, and I forgot to plug the user guide, right? We do have an FRQ user guide. I think we're working on finding a way to make that more available to people. I don't remember if we had a plan on that, but or posting it on a website or.
Yeah, I can speak to that a little bit. So I am currently working. We want to kind of take some time to review it for any updates that may need to be made to it. But our plan is to be able to put both the FRQ and a step-by-step walkthrough through OHMS on how to administer one up on our website. So that way it is accessible to everybody. So it is a goal of ours that we're working on.
A few more FRQ scenarios. So these are kind of questions from the grab bag. You know, we have a positive FRQ, but we see due to a delay in the claim allowance, the worker's just starting PT. What could you do about that? Or the worker returns to work prior to their PT completion, and some providers don't want to refer to additional services until PT is completed. So I think this often ties into PGAP. People think about PGAP often with FRQ positive, and then there are some thinkings about whether PT and PGAP can be done at the same time, and yes, they can. So you could definitely do PGAP for some of these. The trick with PGAP is that they have to be 5 weeks post injury, and so FRQ positive and PGAP is actually going to line up fairly closely depending on when you're doing that. Usually the FRQs are triggered in like week 2 to 6. So, you know, even at the very earliest, we're saying like week 2 or 3 is by the time you'd have talked to the worker, you know, done an FRQ, figured all that out. If then you make a referral to PGAP or talk to the attending provider, get on, you know, talk to them. They say, yeah, let's do PGAP, make that referral. You know, still that's probably week 3. And if they were positive and you referred them to the PGAP program, probably what's going to happen is they're going to say, okay, FRQ positive, you know, they're not going to get into the PGAP system maybe for a week. They might delay them and then put them in so that by the time they get scheduled, it is week 5. So I think it's still something that you can start that process, and that's sort of best case scenario. A lot of FRQs, you know, may be delivered in week 3 or 4, and that's not even going to be an issue there. If the claim's allowed, but PT cannot get the worker in for 2 to 3 weeks, again, if we're past that 5-week window, you could do PGAP. None of the other things rely on having PT completed. So if they need behavioral health interventions and they have fear avoidance, start them off on that, right? They're going to do better in physical therapy if they already have addressed all those activity, you know, behavioral avoidance pieces. And sometimes the AP might not want to change to a treatment plan that's more costly until PT has failed. I don't think we want to wait until PT has failed to have them do PGAP or add behavioral health, right? We're looking for building on success here rather than, you know, waiting for failures. So I would encourage you to encourage that AP to say, well, think about PGAP or behavioral health or one of those other pieces before PT is failing, that we could have avoided that delay and that downslope, right? If they've already been through 12 visits of PT and they're not attending and they're not engaged and they're doing poorly and failing at it, that's going to become harder and harder to recover from. And the last one is that provider has their own clinical protocols where they're unwilling to change their processes. Yeah, I don't know how you get around that one too much. That's about navigating it with that provider. If their processes are great, maybe they don't need to change it. If they aren't, again, I think that's where you might talk to a claim manager. They're going to get that FRQ OH note as well. And if you're saying on there, look, there's no connection with the employer and they need voc services, that doesn't require the AP to sign off on that, right? So you may be able to get some movement from the claim manager as well, or partner with them to reach out to that AP to say, hey, we're really concerned about this worker. Have we thought about some other services to help them? And then I want to say any questions in the chat about, or comments of, what would you do in these situations or related scenarios that we can answer? All right. I'll take the silence as your implicit agreement that you like my solutions and answers then. Super users. I want to plug your super users. We spent a lot of time with super users a few years ago, working through a lot of these same conversations. And now you have a couple years under your belt. I encourage them to reach out to me and ask any other questions or things that have come up. Like Wendy mentioned, we're going to try to update that FRQ super user guide. So now's a good time for input. If with your experiences having done this for a while now. And here are your super users listed out. So lean on them. They're your resource. And super users, you can always lean on us if you have questions that you can't answer. We're here for you too. Wendy's the super user owner, and I'm the FRQ psychosocial person around here. So any other questions? Experiences?
Dr. Young, this is Jamie. I'm just curious about downstream sort of tracking and monitoring. So once you've identified that the FRQ is positive, what efforts are happening within L&I to see like what interventions made the most impact, or like what's happening downstream after HSCs are identifying that it's positive and they've reached out to the provider and efforts are ongoing with that. What does that look like after that initial process?
Right now, nothing really. It's all you, right? This is a flag for you to have those conversations with the AP and realize that this is a trigger, and to do something. So we don't have, any safety nets and catches other than the claim manager does get a notification when there's an HSCOH note for an FRQ positive. That triggers something in our system. The claim manager looks at it. But they're basically looking to see if something has been done. If there are notes or phone calls from you and the AP, if there's a new referral for some kind of other service or something, maybe a claim request, they might go and make sure that they've dealt with any requests that provider has sent in. But that's really the extent of kind of the triggers. Is it falls to the AP to say, what do we need to do next for this person? Hopefully, once we get all of our data and reporting up in the next, year or whatever it is, then we'll start to be able to analyze this. University of Washington is very interested, of course, in how the FRQ going. Maybe almost as much as Ellen is, but they want to see, how is this going? How has this worked? And we want to know what were the things that were effective. We're probably not going to be able to tease out which things are most effective because everybody needs something different. And there's no way for us to say that, well, just because they're FRQ positive, it means they should have gotten X, Y, or Z referral. It just depends. And so I think the data interpretation is going to be more around how many FRQ positive people got something. Did they get a referral to somewhere? Was there a change in their frequency of visits with their AP? Things like that. And we're just going to kind of look for what interventions were happening, and that it is triggering interventions more so than which one it was. There's not going to be an answer to which is the right intervention to FRQ.
Yeah, that's great. And then my other question is the FRQ being used any place besides Washington? Is it being used in other populations or?
Yeah, well, so I don't know. We've had quite a few people that were interested in it, quite a few other systems, work comp systems that have looked at it, talked to us about it. Some of the retained grants, I think we're using something kind of like it, and some of the concepts around screening people, but I don't think they're using it directly. It's freely licensable from UW, so I think I've had a couple of requests where people wanted to use it, and I think other people maybe are adapting those concepts and ideas. But that idea of finding a way to address who's at risk and then finding them an intervention, I think is becoming more and more acceptable in work comp. I haven't checked up on retain grants lately, but if for those of you who aren't familiar with retain, it was a department. Who ran it, Jamie? Department of Labor or something?
Yeah, it's Department of Labor, and it was 8 states that were involved, and Washington was one of them through the ESD department. And but now they've got 4 that are working it right now, but I don't know how they were incorporating it. I was just curious if there was any other work comp systems doing it.
Yeah, they're essentially taking kind of our COHE HSC kind of models and iterating on them a little bit and trying to apply them to non-work comp situations. Yeah. We're pretty unique in Washington because we have the COHE program and the HSCs. Most places don't have that. And so it's tough to implement that, although some nurse case managers and places like that are thinking about these same kind of ideas. We also have vocational recovery counselors, which a lot of other places don't have, or not quite the right system. So I think we're uniquely set up to have these safety net systems and catch these people. So hopefully we can show that that's really actually working and is doing something. And now that we have a couple years of data from the COHEs that have been doing FRQ and contacting APs, I think it'll be really interesting to see how much impact that has on attending provider behavior, because I think that's where, you know, they fall through the cracks and don't get that support that they need. Good questions.
Do we have any other questions, comments?
This is Patty Frazier again in Spokane. You know, I mean, in an ideal world, it's not an ideal world. Let's just put it that way. With claim review, adjudication, allowance, I don't see as many auto adjudicated as I'd like to see, but then again, sometimes I see where the auto adjudicated ones get kind of slowed down once a claim manager takes a look at them. But I think claim adjudication has at least gone, you know, been retarded at least another week lately. And I'm just wondering when Department of Labor and Industries is going to really make a big effort of recruiting and getting more claim managers trained, because it sets back everything when you can't get a claim allowed or, you know, at least adjudicated, because therapy, you know, physical therapy clinics won't start treating usually. You know, I don't know what other interventions. I don't know if PGAP, the claim has to be allowed in order for PGAP to start. Vocational counseling won't start.
Right.
All these different things. So I think the FRQ, great. It's great. You know, I don't mind doing it at all. I can kind of tell by just because I've been doing this for so long, which ones are going to be positive. Sometimes I'm surprised. But I'm just wondering when Labor and Industries might be tackling that claim manager shortage.
So that answer's probably way above my pay grade. That's something that, you know, Joel Sachs, our director, is constantly talking about. I know it's a huge struggle for L&I to keep claim managers, and COVID hit us pretty hard. We were actually doing pretty well in our claim staffing for a while there, and it has been very difficult. I think claim numbers, don't quote me on this, but I think they almost doubled from what our best was to what our worst was during COVID. So yeah, that might reflect the delays that you're seeing. There's always a huge recruiting effort and staffing effort. They're constantly training up new claim managers. And I don't know what the right answers to solutions to having them stay more permanently are. That's again way above my ability to answer, but we totally agree with you and see the issue and wish we could retain our claim managers too. It's like a 18-22 month effort that goes into training claim managers, and it's a sore loss when we lose them. Great. Well, thank you, and hopefully I've impressed upon you that this my summary is FRQ is really just a screening tool, and it really relies on you and the attending provider to act and find solutions for that person. It's just a standardized way of ensuring that happens and that nobody gets missed or has a brave face, and you go, I'm sure they'll be fine. And then we look at FRQ and go, well, maybe you will be, but given these pieces, let's add a little extra effort here and make sure this person moves forward.
Awesome. Thank you so much, Dr. Young, for taking the time to share all this and do this recap with everybody. Again, if you have any questions, you're welcome to reach out to me, or you can reach out to your contract manager or Dr. Young, correct?
Yep.
So I will be sharing the slide deck along with the document that Dr. Young sends me. And I also did receive several questions prior to, and there were some that I don't know if they were fully answered in today's presentation, but I will go ahead and send out kind of like a question and answer sheet that I had been working on. So that way, hopefully all your questions get answered. But I really appreciate everybody taking the time to attend today, and I hope that you all have a great day. Amy, did you have anything else to add before we end?
I did not. I just want to thank you guys for both making the time for us and for allowing us to record this presentation so those who weren't able to attend can take a look at it. So I appreciate everything you guys did for us today.
You bet.
No problem. All
Thank
right.
you.
Well, everybody have a great day.
Take care.
You too.
Thank you.